for having that done before I start. All righty. Okay. Good evening, everyone. Welcome to our first research club of 2022, hosted by the Brain Health Center of the Rockies. My name is Kathy Kiefer, and I am the president of this nonprofit organization. Tonight, we have an exciting presentation from Dr. Augusto Miravalle, who will be discussing the latest research on multiple sclerosis and the Epstein-Barr virus infection. It is with great excitement to see that we are making gains on better understanding the cause of MS. The intent of our research club is to bring the latest developments of recent academic journals and have them explained in a way anyone can understand by a panel of experts in the field. Research Club is a free program to our participants and is held 4 times during the year. Our next 3 research clubs will be on May 2nd, where we will discuss advances in pain care, September 12th, with the topic of air pollution, global warming, and brain health. Is there a connection? And lastly, November 7th, with the topic of food for thought, food, nutrients, and the brain. Today's event is being recorded and will be made available via our website, www.brainhealthcr.org, within the next few days. All of our research clubs will be held on Mondays at 5 p.m. Mountain Standard Time and will last 1 hour long. Our moderator and co-chair for our research clubs is Dr. Brett Fling. And of course, I would like to recognize our sponsors for tonight's program, which include Biogen, EMD Serono, and Janssen Pharmaceuticals. You can visit their virtual exhibit hall with information regarding their products via our website. Before I turn things over to Dr. Fling and Dr. Miravalle, I would like to dedicate this program tonight to a special person, Bill Elizalde. Bill was raised in California and joined the US Army on January of 1981 and retired in January of 2002. He spent half of his military career as a Green Beret in the 10th Group, headquartered in Germany. His final post was at Fort Carson, Colorado, where he met our dear friend, Jeannie Kelso. After his retirement, he moved to Fort Collins, where he married Jeannie and enjoyed many years of working with horses, camping, gardening, spending time with Jeannie's grandkids. Bill had an unexpected and fatal stroke on March 6, 2020, and passed away 2 days later on March 8, 2020, nearly 2 years ago to today. He was able to be an organ donor, which was his final request, and was able to save lives of several people in Colorado. We want to thank him for that. At this point, I'm going to turn it over to both Brett and Dr. Miravalle.
Well, thank you very much, Kathy, and thanks to everyone joining us. Good afternoon or good evening, maybe good morning. Now you could be joining from anywhere around the world, I suppose. And I wanted to thank you all for taking time to be with us. And I think one of the cool things about being in science is the ever-changing information that comes out. So we had actually planned a different topic for our first research club of the year here in 2022, but a paper that was published in Science magazine in January of 2022 has gotten a lot of people in the MS community talking and inspired us to not be dopes, and we better jump on the cool new information that's out there. And so we're going to talk today about the potential role and relationship between the Epstein-Barr virus and multiple sclerosis. This was a really impactful work done by a group of folks, primarily from Harvard and the Harvard Medical School. If you're not familiar with that, we call it the CSU of the East. It's very similar to Colorado State. but just slightly less well known. And we're going to walk our way through a wide variety of components of what Epstein-Barr is, how it might relate to MS, and what that means for all of us. One of the things we always want to strongly encourage folks to do is we're going to take a variety of breaks as Dr. Miravalle is going along, and to ask questions and just break up the talk a little bit. So we strongly encourage folks, you don't need to wait until the end. You don't need to hold your questions. There's a Q&A box at the bottom of your Zoom screen. And so we'll just encourage you, anytime a question pops into your head, feel free to just type it into that Q&A box. And I will be interrupting Dr. Miravalle every now and then and asking him some of your questions, as well as I've got a few of my own chambered that I want to ask him too. He understands this stuff a lot better than I do. So I think with that in mind, I'll turn it over to Dr. Miravalle and we'll get started, but just want to encourage everyone, please type your questions as you think of them.
Excellent. Well, thank you, Kathy, and thank you, Dr. Flynn, for the introduction. And it's a pleasure being here. And as Dr. Flynn mentioned, this is a very exciting topic, and it was recently published, but it's something that the scientists and researchers, they've been working on it for decades. So let's start with the first question. So we level everyone's in the very basic concepts of, what is MS and what is Epstein-Barr and why are we talking about that? So in the right upper corner of the slides, you'll see some icons and pictures that I put today to just to kind of like make things a little bit more interesting. And this is the first depiction of an MS patient. Actually, it's a painting from 1898. I'm sorry, 1498. So 1498, before the 1500s. And this is Saint Lidwina. It's known as the first person depicted with MS, even though the disease was not recognized until the 1800s. In retrospect, what she had probably was MS, was a relapsing course of a neurological disorder that will cause imbalance and falls. And she was an ice skater. And since then, she was known as a patron for the deceased and sufferers, as well as ice skating. And it's thought to be, again, the first person depicted with multiple sclerosis. I always like to remind myself about the history of what we do, just because so much has happened in the field of multiple sclerosis that sometimes it's hard to put that into context. And nowadays, we know that MS is an immune-mediated disease, it's chronic. We don't have a cure, and up until recently, we didn't know the cause of multiple sclerosis. But what we do know is that the immune system plays a primordial role. Without the immune system in MS, the disease itself will not occur. What we didn't know is what triggered that immune system to actually get activated and go after your own cells. Epstein-Barr virus, it's been seen traditionally as that agent that perhaps was involved in the pathogenesis of multiple sclerosis. We also know that there are other factors like genetic factors, right? Up to 10 to 15% of patients with MS have a first-degree relative that has multiple sclerosis. And perhaps the most obvious natural research study looking at the familial history of MS is when you look at natural identical twins with MS, and you see that when someone has an identical twin with MS, your risk of MS increased significantly. And there is an HLA, which is one kind of like the prototype of your immune system, a marker that it's coded by your genes, that has an increased risk of MS, thought to be a threefold increased risk of MS, is known as the HLA-DRB1-15. So we know that individuals that has that marker in their immune cells have a threefold increase of multiple sclerosis. And this marker actually will determine how your immune cells are going to respond to external antigens, whether it's viral infections or environmental factors. So let's now shift gears to talk about what is Epstein-Barr. It's also known as the virus that causes mononucleosis, or the kissing disease, right? Because it's an infectious disease that is transmitted by saliva. And this virus, it's going to enter your body through the oral route, and it's going to live in those B cells inside your tonsils. And from there, it will go everywhere else. So this virus has a tropism, a predilection to involve these B cells, which are one of the types of immune cells that we have. And like many of the herpes viruses, once it enters your body, it will never leave, stays with you for the rest of your life. And that's why it became an attractive model for multiple sclerosis, because we know that whatever triggers MS has to stay with you. And that's the reason why you have relapses. And that's the reason why you have this chronic progression of the disease. Whatever factor initiates the disease is something that has to stay with you for the rest of your life. And that's why this virus, this model was very attractive. The other reason is because in an attempt to survive, Epstein-Barr virus mutates. And one of those mutations, it creates a protein in the external surface of the virus that looks very similar to proteins in the myelin, in the nerves in the brain. So that mimicry that the virus creates is an attempt to avoid the immune cells from destroying the virus and recognizing it. So that's something we call in medicine molecular mimicry. So those two things made this virus very, very attractive as a reason to explain multiple sclerosis. But Epstein-Barr is not only involved in MS, but also involved in other disorders. As you can see in the slide, it's been associated with lymphomas, particularly B-cell lymphomas, Hodgkin's and not Hodgkin's lymphoma, as well as other type of cancers. So it's a virus that actually has been studied widely in medicine. Up until now, we don't have, unfortunately, a vaccine to prevent this infection. But as you will hear in the next few slides, that's something of great interest. The other thing that I thought to bring as part of the background review is most of us are exposed to this virus, and 95% of the population is being exposed to this virus. What is different is when in our lives we're exposed to. And there is a link between geography, there is a link between sanitation and the exposure to this virus. In places that are developing countries, where sanitation is poor and infections are more prevalent in early years of life, individuals are exposed to this virus very early in their life. Whereas in developed countries, like in the US and Northern Europe, individuals are protected from this virus and their exposure happens later on in life. And a rule of thumb in immunology is that if you are naive to some environmental factor and then you expose later on in life, the mechanisms involved to prevent autoimmune reactions are not as good. Our immune system is very active, very trained, and very young early on in life. And that's why usually if you get infections, the chances of abnormal responses to those infections is lower. And that's why sometimes these abnormal responses to external factors happen later on in life. And you see that geographical difference in multiple sclerosis that in a sense mirrors that difference in exposure to the Epstein-Barr virus in different stages and different ages throughout life. I want to make sure that I pause to see if there are any questions or comments. So let's dive a little bit deeper into that relationship between Epstein-Barr virus and multiple sclerosis. We know that there is an increased risk of MS after someone is infected with this virus. And that's been seen by not only markers of this viral load in people's blood, but also the presence of the virus has been seen directly in the MS lesions in pathological studies, but not in all. So there was always this controversy, well, why not everyone has the Epstein-Barr virus? So that's why we were never truly ready to put a confirmatory presence of the virus in multiple sclerosis. We also know that there is a higher rate of reactivation of the virus in people with MS, and that's been linked to also the presence of clinical relapses. There is a researcher that has been doing extensive work on this relationship, is John Pender at the University of Brisbane in Australia, and he has done extensive work in trying to look at the relationship between the virus and the B cells and why MS happens, to the point that his research led to a clinical trial, a new medication or approach to MS, which I will explain at the end of today's presentation. But many of the things that we know today is due to his work. But as I mentioned before, up until recently, we always thought of an association, but this concept of causality was never proven. I don't know, Brady, if you
Dr.
have any thoughts.
Yeah, I was going to ask if you mind if I jump in with a few questions. So we've actually had several comments and questions going so far. And one of the questions is, are there different strains of Epstein-Barr virus? Are there different kinds of EBV?
Yeah, so like many herpes viruses, there are many types. There are two types of EBV, type 1 and type 2. The differences are subtle and mostly clinically it's hard to distinguish between the two.
And one of the questions or thoughts from folks online right now is, so is it possible that maybe people in the same family who've developed MS have the same strain of EBV? Is that a likely option?
Well, it's a great question. So when you look at the familial causes of MS, those clusters of MS in families, most of the times are explained by genetic factors. However, as we all know, it's very likely that if there is an environmental factor, and assuming that family members live together, very likely everyone is exposed to the same environmental factor. So it's very difficult to discern whether the familial clusters of multiple sclerosis are purely driven by genetic components or that genetic and epigenetic correlation. That means the genes and the environment playing together.
I think that's a really interesting, and you're pointing out a number of other components that may come along with Epstein-Barr virus that it's known to be an underlying cause of. And so one of the great questions we have is if someone has EBV and MS, are they at a higher risk of developing these other diseases that EBV can cause?
And yeah, and it's something that we'll cover in today's presentation, which has to do with the chicken and the egg, right? So how do we know that EBV is the first event that then triggers this development of multiple sclerosis versus how do we know that perhaps people have MS and as part of the disease itself that creates an abnormality in immune responses that predispose people from having more infections, and that's why you see EBV, right? So what came first? So this study that was recently published kind of shed some light into, no, it seems like EBV went first, and we'll cover that.
So this is maybe a really nice segue. So if you have been around science or scientists, one of the phrases you'll hear often is that correlation is not causation. And
right.
So within this paper, right, we're seeing a correlation or an association between these two components of Epstein-Barr and MS. So maybe you can walk us through now, how do we establish causality? How do we go from correlation to causation?
Exactly. Well, thank you. And so basically, this is the principle, right? So causality will imply that individuals who develop MS after EBV infection would have not developed MS if they had not been infected with EBV. So the causation will be established once you are certain that EBV was the factor that caused MS. And without that infection, MS would have not happened. It's very difficult to establish that in a disease that is so heterogeneous, that has so many different clinical presentations. And we know that it's not just one factor that causes MS, right? However, I think this study tries as best as we will ever can to truly establish this causality. And why is it so difficult? Well, when you look at MS, as we were alluding before, there are different components. It's a multifactorial disease. You have genetic components, you have environmental factors. We talked about some of those, but are well-known and established factors like vitamin D deficiency, smoking, geography, diet, and those factors do play a role in increasing the risk of MS. But also biological factors, right? We were talking about other autoimmune disorders and other comorbidities that actually perhaps explain a higher risk of MS. We also know that MS is not caused by a single event. So you cannot transmit the disease, it's not contagious, it's not like any other infection. So it's likely going to be a combination of multiple factors. So how do you study causation? Well, the ideal population has to be large, has to include multiple individuals as diverse as possible, but still they have similar exposure, similar characteristics, similar environmental exposures, and individuals that actually you have longitudinal data to follow over time, clinical, ideal laboratory data. So when you look at that population, the researchers at Harvard University School of Public Health thought, well, let's go after the US military personnel. We have a large database of samples, people from all different backgrounds that we can follow over time. And that's another reason why we thought to dedicate today's talk to Bill, because he was involved in the military, and also through Jeannie's relationship. Jeannie has MS, and we thought, well, what a wonderful combination of factors, right? And not only our military personnel are keeping us safe, but also perhaps through this study are giving us the clues to understand MS, right? So that's what this study was all about. They looked at over 10 million samples from soldiers and recruits that were studied between 1993 and 2013, and they followed those samples for 20 years. So what they looked is how many of those were EBV positive. And not surprisingly, 95% of people were positive. So they focused on those who were EBV negative, which was approximately 5% of the entire pool of individuals that they had. So that led to over 100,000 young adults that were negative to EBV at the time of this study. So those are ideal patients or individuals to follow, because you know that they were never exposed to the virus, and then you can try to understand, okay, what happened if they're exposed, and are they going to develop MS later on? So among that group, they found that 955 MS cases were identified. So they have now this population of individuals, very diverse, that they have data on, that were initially negative for EBV and later on develop MS. So of course, not everyone had all the samples they wanted, so the number was reduced to 801, and all except one were positive for EBV. And that individual that was not positive later on seroconverted to EBV. So the thought is that perhaps was not initially, but then became positive. So of those, they have full data on a kind of like the temporal relationship of 35 individuals who develop MS after seroconversion to EBV. And they found that the time between exposure to the virus, seroconversion, and development of MS range anywhere between 0 to 10 years, with an average of 5 years. So this study was done in these 35 individuals who was a subset of individuals who we have samples that seroconverted to EBV and then became, they developed multiple sclerosis. And this is the chart that actually perhaps explains this concept of risk of EBV related multiple sclerosis. So the question becomes, well, what if there are other viruses? What if there are other causes that perhaps explain these relationships? So not only they looked at EBV, but they looked at other viruses, including CMV or cytomegalovirus, which is transmitted in a very similar way, and individuals could be exposed in a very similar way. So what they looked is what happened when you seroconvert to EBV in terms of risk of MS versus other viruses. And as you can see here, individuals who later on develop MS, which are represented in these green lines, they had a 32-fold increased risk of MS after converting to EBV, and that risk was not seen after converting to CMV. So basically the question to, is this just one of many viruses? What happened with other infections was answered by this study in the terms of MS has not happened after exposure to any other viruses. It only happens after exposure to EBV, at least in this large group of individuals. So they not only looked at seroconversion to EBV and multiple sclerosis, but also they looked at other markers, and perhaps the most interesting one is the neurofilament light marker, also known as NFL. So NFL is a marker that tells us that something is happening in the central nervous system. There is a breakdown of proteins in the neurons in the central nervous system, and it's been a very popular marker in multiple sclerosis. We know that elevations of NFL happen even prior to the first symptoms of multiple sclerosis, up to 6 years prior to the first symptoms of MS. Also, elevations of NFL happens prior to relapses, right? So it's a marker that's been studied as not only a predictor for multiple sclerosis, but also a predictor of relapses or inflammation. So what the study tried to look is, okay, what is the relationship between seroconversion to Epstein-Barr, NFL, and multiple sclerosis? So on the bottom of the slide, you can see a cool graph actually that tells us that spike in green is the age at the first sample of positive EBV. And you can see that most of the individuals in the study seroconverted to EBV in between 15 and 20 years of age. So it's later on in life as expected from a US-based sample, but still younger in life, right? In between 15 and 20. And you can see now in the blue graph that that's the age of onset of those same individuals from MS. So you can see that is this lag between seroconversion and first symptom onset. It's approximately 5 to 10 years. So as we were talking before, Brett, so the question becomes, okay, there is a temporal relationship between EBV and MS. How do we know that perhaps MS was happening even prior to the onset of symptoms? And as part of the disease process, individuals had a higher chance of developing infections, right? We know that it's an immune-mediated disease, so why not speculating that perhaps the MS itself increased the risk of EBV as opposed to EBV increasing the risk of MS? Something that is known as this reverse causality, right? I like to think of that as the chicken and the egg theory, right? So what came first? So that's when the scientists used NFL to try to explain that. So NFL, as I explained before, also known as serum neurofilament light, is a product of the degradation of proteins inside the axons and the neurons in the brain. It's a marker that is being studied now, and not only helps us understand this breakthrough of proteins in the brain, inflammation, but also predict many things in multiple sclerosis and other neurological disorders. So NFL level increased at least 6 years prior to the first clinical symptoms of multiple sclerosis. We also know that NFL correlates with relapses, with progression, and MRI activity. And studies have shown that there is a spike of NFL levels even months prior to new lesions on an MRI. So it's a very early marker of inflammation. We also know that when we treat MS with anti-inflammatory therapies, NFL levels go down. So that's something that is being done in research environments. There are now few opportunities to use NFL in the clinical context. We are still trying to understand what are the levels, what to do with it, and how to clinically use it. So it's not right there to use clinically, but it's something that probably will happen in the very near future. However, going back to this study, the researchers looked at the levels of EBV related to the NFL. And what they found is, this is a little bit of a busy slide, but I'll walk you through, is here in green, you have patients with MS, and in blue bars, you have patients without MS. So in the first chart, you see that those are the neurofilament levels prior to EBV infection. And you can see that MS patients actually had lower levels of NFL, and non-MS patients have higher levels of NFL. Then you see in the middle graph, the NFL levels at the first sample that patients developed EBV, right? So again, in green, you have MS patients, in blue, you have controls. And you can see that there is not much of a difference, right? So NFL levels were very similar. But look at what happened in patients with right after the infection with EBV, those who develop MS, right? So after the infection, you can see that the NFL levels goes up, and then people that did not develop MS, NFL levels are lower too. So in the bottom of the slide, you can see that visually that, again, in green is MS patients, in blue is patients without MS. You can see that NFL levels will go higher after the EBV infection, right? So in between, someone seroconverts to EBV and develop multiple sclerosis. So that is something that's giving us a clue that in terms of what came first, very likely EBV infection came first, and then multiple sclerosis came second. And this is just to show that kind of relationship, that's a theoretical model that, you know, someone first develops EBV infection that triggers some sort of damage in the CNS. We can measure that through the elevation of NFL levels and subsequently develop the first symptoms of multiple sclerosis. And that relationship could happen anywhere between 5 to 10 years.
Dr. Miravalli, do you mind if I jump in with a couple of questions for you?
Please.
So we've got some great questions coming in through the Q&A, and we've had a pretty lively discussion in the chat as well. So I want to thank everybody for participating and interacting. This is obviously a topic of some interest. You know, a few questions sort of around EBV for you, Doctor. Is asymptomatic Epstein-Barr less of a risk if you have really severe EBV as a child? Maybe you have a real serious case of mono. Does that make you more likely to develop MS over time?
Yeah, it's a great question, because there is a relationship between also age of exposure and likelihood of symptoms, right? So most individuals who develop EBV infection early on in life, prior to the age 15, most likely won't have symptoms. So most of the childhood EBV infections are asymptomatic, and very likely, conversely, EBV infections later in life have a higher chance of having symptoms that also correlated with a higher chance of having complications from that EBV infection.
Okay, that makes sense. And I think our next question will actually really dovetail nicely into where you're going next with this discussion of how EBV stays in your cells. One of the questions is, you know, what if we get EBV or mono? So in the previous graph you showed, or a few graphs back, that a common age of onset of EBV or seroconversion is maybe in that age of between 15 to 20. So what if you contracted at that point, but then you don't actually develop or get diagnosed with MS until you're in your 50s or 60s even? Does that still make sense?
Yeah, it does. And we do know that some patients with MS, the disease itself starts in younger years, and due to many factors, including the presence of brain reserve that we talked a lot during the brain health program, due to compensatory factors, due to the fact that perhaps the disease has a milder presentation or perhaps a progressive onset, the symptoms won't maybe manifest for decades after. But the thought is that the disease itself starts in most individuals in their early 20s. Something I want to clarify is that I don't want to convey the message that anyone that develops EBV will have MS, right? So as we saw, is only a small proportion of individuals, and within that small proportion, it's only a fraction of those who develop multiple sclerosis. So even if you do develop EBV infection later on in life, that does not mean that you will go on to develop multiple sclerosis. So good question. So let's move on then to, so what happened after someone gets infected? Where is this virus going? This virus loves our B cells. So it has a predilection for these B cells. Immediately goes in the tonsils, look for those B cells, and will never leave. And simultaneously to the publication of this paper in Science, there was another paper that came also in January 2022 that in Nature that looked at what happened with the EBV infected B cells. And basically this is clonal expansion of B cells. It's almost like it has multiple photocopies of the B cells and clonally expand them throughout your body, right? And all of a sudden, most of your B cells become EBV infected B cells. So going back to Pender's theory on MS, what he proposes is, okay, the first step is EBV gets to your body, goes to your B cells, clonally expand them. Why someone develop MS and someone doesn't? The difference is in the ability of the T cells, the other type of cells in their immune system, to actually clear the infection and prevent this clonal expansion of B cells, right? And that in a sense explained why someone develops MS after EBV infection and why someone doesn't. And the ability of the T cells to clear EBV infection is determined, among other things, by your genes. And that's where, everything is coming kind of together, all the pieces of the puzzle saying, okay, we know that EBV plays a role. We know that the immune cells play a role. And now we understand what role does the gene or your genome play in trying to kind of clear that infection. So what he proposes is MS is a failure of T cells from clearing EBV infected B cells, right? That's kind of like the theory behind what causes MS. So I decided to just spend some time this weekend, and I was playing with animation. So I apologize for my nerdiness, but I kind of enjoy that. So what you see here is hours of my time during the weekend. EBV is depicted in this red star, and it's going into your B cells, right? After it enters your body. And what happened after that is there is this clonal expansion of EBV infected specific B cells. So what is going to happen then is your T cells are going to recognize that something is wrong with your B cells. They shouldn't have those markers outside, right? Those markers don't belong there. Most individuals will be able to clear that and get rid of it. And still your EBV cells stay there, but they don't do anything. You just have few cells that are infected, but just don't do much. In certain individuals, that process of clearance doesn't happen. And that's when these T cells start developing other factors, other proteins in their membrane. And those proteins actually are going to kind of train or mark them or prime these T cells to do something wrong, which is go to your brain and find something that looks like EBV, but is not truly EBV. And these T cells are going to go inside the brain, identify myelin, thinking that is something they need to destroy and cause demyelination. In addition to that, what's happening is that these EBV infected B cells are also going to go to the brain because they think, okay, this is our territory. We are going to stay here to make sure that we are protecting ourselves and we keep fighting these immune responses. And that's been shown that MS patients have this accumulation of B cells in the brain and in one space of the brain that is the meninges. So the meninges are these wrappers around the brain, right? And there's a specific portion of the meninges called the subpial portion. In MS patients, it's been demonstrated that they have these ectopic follicles of B cells that stay there in the subpial structures in the brain. And not only that, but there are lesions right underneath that in the cortex. Those are the cortical lesions that have been recently discovered. So the thought behind is that these EBV infected B cells perhaps once travel to the brain, stay there, and those are the ones that keep triggering these inflammatory responses from T cells from the periphery and also from other cells inside the brain known as the microglial cells. And here I have some pictures for you. I'm a visual learner, so I have to see it to believe it. And you can see that, in MRIs in the top here, you can see in vivo individuals with a 3 Tesla, you can see a little bit of that. I don't know if you can see my arrow, but there's this white signal in the meningeal spaces. There is a zoom in the middle of the slide that show that inflammation in the meninges. And in individuals who died and donated their brains to research, you can see the postmortem studies on MRI as well, but also in pathological studies showing this accumulation of B cells in the wrappers around the brain, the intermeningeal spaces in the brain.
You'll be happy to know that you got a lot of love for those animations within the chat room. Violet in particular was quite impressed with the work you put together. So Dr. Mirabali, with that as sort of an underlying idea of maybe the mechanism of MS, what happens then when there's we've got a relapse and a remission phase of MS? So when there's a relapse that occurs, is it just this whole process sort of starting over again that's triggered by something?
Yeah, and all of this is speculations, right? But the thought is that, like many herpes viruses, right? I mean, we are very familiar with the cold sores, right? And which is kind of like the same, or shingles, right? People have these viruses that stay somewhere, and then they have these constant reactivations, right? For stress reasons, for sun exposure, whatever it is. So the thought is that the EBV-infected cells also reactivate in a sense and cause that trigger of new inflammatory lesions. And the immune system is way more complex than just T and B cells, and even within the substrate of T cells, you have different subtypes of T cells, right? We know that the regulatory T cells are the ones that are going to stop inflammation, right? So, and that's why we see this relapse and remission, right? So you have the acute inflammation where the pro-inflammatory T cells are causing disease, and then you have the good guys, the regulatory T cells coming after and say, well, you need to stop that. And that's why you see this relapsing course of multiple sclerosis. There is also a progressive form of the disease that, all patients have progression, but the thought is that perhaps there is also some degree of chronic inflammation that is happening that may be independent from this process of relapses, that is explaining things like atrophy, or is explaining things like slowly enlarging lesions in the brain, which is kind of like the new hot topic in multiple sclerosis, explaining how are these lesions growing, that inflammation is different to the inflammation present in relapses. So there is a lot to learn from MS, but the truth is that the EBV reactivation theory fits nicely with the relapsing portion of multiple sclerosis.
Yeah, it really does. That makes a lot of sense. You actually just touched on one of the other questions we had in the Q&A is there anything that we know at this point that would allow us to differentiate between maybe the type of EBV you have when you're younger that then leads to the different forms, so these different subtypes of MS. So is there anything that we can say at this point as to why someone, might develop relapse remitting versus
Great question, though. It's a great question. What we do know is that one of the consequences of that first infection that some patients have is the presence of oligoclonal bands on the spinal fluid, right? So those are immunoglobulins that up until recently, we don't know what they're doing. There might be a relationship between the presence of oligoclonal bands as a consequence of EBV infection. And we also know that the presence of oligoclonal bands is sometimes, not always, but a marker of worse clinical outcomes, more likely to progress in a progressive phase, particularly a subtype of oligoclonal bands, which is the IgM. So we are starting to understand what is the relationship between the type of infection, the time, and all these markers, but we don't have anything that we can actually truly confirm.
Okay. No, that's really interesting. Well, I think, I want to make sure that I'm keeping us on time here, and your next slide sets us up nicely. I had no idea until a couple of years ago we would spend so much time talking about vaccines, but is this, as simple as, so your question on the screen is how do we stop this? Is this as simple as developing some sort of EBV vaccine that we all take at the age of 6 with our measles and mumps vaccine?
That will be fantastic, wouldn't it? Right. And, again, that not to get off topic here, but hopefully this reminds us of the danger of these viruses, right? And we never know what are the consequences, long-term consequences of the virus. Even if it is a minor symptomatic presentation, there could be some downstream consequences that happen with all of these viruses. So another reason to get vaccinated for whatever you can, COVID-19, whatever you can, because you never know what's going to happen. If you have a vaccine, please use it. So unfortunately, we don't have a vaccine for EBV yet. Moderna is working on. There is currently a phase 1 trial in Boston happening. They are using a similar kind of approach and technology to develop this vaccine to the one that was recently developed for COVID-19. So it's an mRNA vaccine. And they're looking at the very early stages, phase 1, and safety and all the different things. But the concept will be, one way to stop this is prevent anyone from getting EBV, right? So that will be perhaps the most successful way as a public health measurement to stop MS, right? So if truly EBV is the first step, let's get rid of it, like we did with polio. And, polio is another example, right? If you go back to the time, 90% of people will get polio early in life and nothing happened, was totally asymptomatic. There was only a small proportion of patients who will get the neuroparalytic polio, the one that we are all familiar with, but it's a small proportion, right? We didn't study polio that much like we did with MS, because what happened is we developed a vaccine, people got vaccinated, and it's gone, right? But if that didn't happen, perhaps we still would have had to suffer from these many cases of polio. So that that will be a wonderful thing to do. Get a vaccine, vaccinate people early on in life and get rid of it. Another way to stop that will be something that is happening now. And we actually are a site for this clinical trial. And I have to say, Brett, from all the trials that I've been involved in the last decade, this is perhaps the most exciting one because it's not a drug. It's not an immune suppressant. This is a cell-based therapy. So what this is an off-the-shelf allogeneic transplant of T cells. These T cells come from a pool of healthy individuals. So you select T cells from people without MS, then you train these cells to go after EBV infected B cells. So you prime these cells to just do one thing, go after anything that looks like an EBV infected B cell and stop it, destroy that. So what we are doing is transplant cells, and of course has to be HLA matched, so there is no potential for risk of that. And once you transplant these T cells, the only thing they're going to do is go after EBV infected cells. And the best part of it, they go outside the brain and inside the brain. So you can get rid of all of the EBV infected B cells, even in those ectopic B cell follicles inside the brain. The study is being currently done. We are enrolling patients. Even the nice thing of the study is that it's not looking for relapsing MS. It's looking for any patient with MS, including progressive MS. And patients can stay on their current disease-modifying therapy. So there is no placebo, there is no need to stop medication. So it's a very relatively easy study to enroll. And we are hoping to truly learn if we can target these EBV-infected B cells and get rid of them. So that's kind of like an indirect way to go after EBV in patients who were already exposed and already developed multiple sclerosis.
Can I just jump in with a quick question while you're on that slide, Augusto?
Yep.
So when you say it's an off-the-shelf therapy, what does that mean? Can you tell us what you mean by that?
Yeah, so what the company is doing is they have this large library of T cells, and these T cells have been, again, extracted from donors, from healthy donors. And these T cells are being organized by HLA type, right? So there is this profiling that happens based on the genetic component and the allele that is present on the cells. So when patients want to enroll here, well, the first thing to do is get a blood sample from the patient and match that blood sample, that HLA, the phenotyping of the patient's blood, to the T cells that are in the library. And so that's perhaps the most difficult portion of the study, to try to match the library of T cells to the patient's blood. Most patients, 85 to 90% of patients, will have some luck to find the right cells, but there's a chance that patients may not have a matched number of T cells in that pool library. So then these T cells, as I mentioned before, will be primed to go after these EBV-infected B cells. So this is kind of like what the study looks like. There is going to be a double-blind period, but all patients will receive the cell-based therapy. So this is done kind of like to delay the treatment so we can see a true treatment effect. So the patients will have, one group will go to the drug right away, the other group will go to placebo, but even those in placebo, they can remain on their own treatment for multiple sclerosis. And then there's going to be a crossover design, which everyone will receive the cell-based therapy at some point. And then, we are looking at, an open label extension. We will have a primary analysis at 12 months. This is a part 2 of a phase 2 trial. We already have data from a phase 1 and early phase 2 trial, and looks extremely promising, the data. Not only is safe, but also, most importantly, most patients were stable and some patients actually improved. So the goal of this study will be not only to stop MS, but if we get rid of these cells, can patients actually improve? So it's a very promising study. We are very excited with that. As I mentioned before, we are currently enrolling. There are different ways you can learn more about this. You can go directly to the company that manufactures this, which is Atara, and the email is right there. You can go to clinicaltrials.gov if you are outside Colorado. If you're in Colorado, there are 2 sites here. One is in Anschutz, and we are a second site here in Fort Collins at Advanced Neurology. So please give us a call and we'll talk to you more about it. There are other ways that we can go after these cells, and this is less specific. This is not truly going after EBV infected cells, but it's going after B cells, right? And we are familiar with the anti-CD20 therapies, ocrelizumab or Ocrevus, ofatumumab or Kesimpta. And there are two other ones in red that are not approved, one soon to be approved, ublituximab, and of course rituximab. So they're all anti-B cell therapies. And what we do is a monoclonal antibody that eliminates B cells. But the caveat here is that there is little data that the medications are going to eliminate the B cells inside the brain. So we don't have a lot of data that is telling us if the use of these medications affects B cells inside the brain. But even if you do just outside the brain, these medications are shown to have the highest clinical efficacy in the current market for MS therapies. Another way to go after B cells is an oral medication called cladribine or Mavenclad. Mavenclad works in a different way. It's not an antibody, but it's actually going to interrupt the replication of cells and goes after B cells. That's the main mechanism. The main difference to Mavenclad is that also has an effect in the CNS. So perhaps has not only an effect in peripheral B cells, but also very likely an effect in central B cells. Studies are ongoing to try to understand CNS-based biomarkers to understand the direct effect of Mavenclad in the B cells inside the brain. And this is just to remind us that this is a medication given as an intermittent dose of administration. So it's an oral therapy, 5 days the first month, 5 days the second month, nothing for the rest of the year. And you repeat that on year 2. And you can see that, and then nothing else for year 3 and year 4. So there is a intermittent immune suppression followed by immune restoration that the effect lasts for 4 years. So it's a very attractive kind of administration. And here on the top, you can see in blue how the lymphocyte count drops. But that drop on lymphocyte count is transient, and most of that is driven by B cells. Last but not least, there is another group of very attractive medications that are coming in the market that also targets the B cells. And nothing specific to EBV, but again, all the B cells. But unlike the anti-CD20 that is going to deplete these B cells, these medications are going to stop the amplification of inflammation that happens after these B cells get affected. So there's an enzyme called the BTK, Bruton tyrosine kinase. This enzyme is responsible for the downstream amplification of events that happen after a B cell gets activated. Among those is this clonal expansion of B cells. So the inhibitors for this enzyme are known as the BTKI, right? So the BTK inhibitors, which their role is to stop this process of amplification. So there are now multiple BTK inhibitors under research investigation. Nothing has been approved yet, but there are multiple phase 3 trials. Here I put the names. We are also enrolling for those trials. That's oral medications at different regimens, different doses. But of course, if you want to know more about these or the other cell-based study, here's the phone number to our research coordinator, Kelly Sage, and also Jen Delcourt. You can call them and they will be happy to give you more information about those studies. So before we jump to the last slide, I want to just allow for some questions or comments, Brett.
Yeah, so thank you. This has been really interesting. The ATA 188 study generated a lot of interest within the chat. Folks had a lot of interesting things to say. So to those of you who are interested in that, within the chat, we've posted that email and that clinicaltrials.gov website that you can access. It's also, I'll be honest, generated some of the best questions we've ever had at a research club. So, you're saying, Dr. Miravalle, that you need to be able to match this library of T cells to the patient's blood sample. So a few questions were, can we use something like the human microbiome for this?
No.
Or is it substantially easier to match with family members because they're more likely to have a similar profile? What are your thoughts on that?
Yeah, so the family members, absolutely. And that's something that perhaps is a question for the company of how they're getting these samples and if someone can actually directly contact them to kind of donate their samples, right? I'll hardly doubt that they're going to say no. In terms of the microbiome, what a wonderful question. So We didn't talk about that today, but there is a clear relationship between the gut and the brain, and the gut and the immune system, right? So this concept of, whatever we have brewing and growing there in our GI system, it's going to trigger all sorts of responses, but certainly immune responses, right? And all of the theories around diet, around salt, around smoking. I mean, all the things that behavioral things that we choose to do with ourselves will have a direct impact in immune responses. So can we then start creating a connection between the factors that we know and MS? Absolutely. And that's kind of like the whole point of precision medicine in multiple sclerosis, right? Which means, okay, it's not just one model fits all, right? But it's like, okay, let's understand your EBV status. Let's understand your genomics. Let's understand what you eat, your microbiome. I mean, all these factors that we know affect MS. And after looking at all of these factors, NFL, MRIs, right? We talked about these biomarkers. We create a profile of who you are, and then we can kind of match your therapy based on all of those things, right? So that will be the goal for multiple sclerosis. We are not there yet, but I think we are getting close.
Yeah, I think that's a great answer. One of the other questions we had that was interesting is, so, a lot of these treatments that you're discussing are sort of targeting B cell therapies, essentially. So what if you're taking something like a B cell eliminating medication like ocrelizumab right now? Do these other therapies work in combination with that, or are there sort of no B cells to attack if you're on something like ocrelizumab?
Right. So we know that the circulating B cells are a small proportion of all the B cells, right? Most of the B cells that we have in our body are not actually circulating. They are in lymph nodes, they are in spleen, they are in these secondary lymphoid organs, right? Unlike T cells, that T cells are mostly circulating, right? So what we can measure with the use of ocrelizumab or any of the anti-CD20s is the effect on circulating B cells. And when we see these results of 0 or less than 1%, well, that tells us the number of circulating cells, the ones that are floating around, going in your bloodstream. But we don't know the effect on the other B cells in the organs, in the lymphoid tissues, in the brain. However, we do know that killing those B cells in the circulation has a profound effect in multiple sclerosis, to the point that it is the most effective therapy. So it's doing something, and it's doing something good for you. We don't know the extent of the effect. And I think that's the next unmet need, is understanding what else can we learn from these therapies.
Well, I know we're probably pushing up against time here. One final question that we've had a few different folks ask, and it seems obviously pertinent and relevant to our topic tonight. Is there a standard test that we can just go take to see if we have EBV, or if we've had it in the past? Is this
Right.
something that we can just go ask at our doctor?
You could, and most likely you're going to be positive. That doesn't mean anything, right? So 95% of the population, and particularly higher if you're over the age of 20, you're going to be positive, right? We know that. And the question is, well, what do we do with that information? It's kind of like not going to change matters. The big interesting question is, like, what if you have MS and you are negative, right? So that will be one of those situations that, well, how do we explain that? Perhaps it's a false negative result. So we don't know, but yeah, you could test.
Well, I think we're right on time here, so I'll let you wrap up if you don't mind, Dr. Mirabale.
All right, so yeah, I have nothing else to say other than thank you. It's been a pleasure, and I'm very excited. As I kind of put here in the take-home messages, this is my view, so take it as you want. I do believe after this that EBV is a primordial and perhaps necessary factor in the development of MS. It's not the only cause. We know through this study that EBV infection is associated with a 32-fold increase in the risk of multiple sclerosis. Then the second to that is the presence of an HLA-DRB115, which is associated with a 3-fold increase. So significantly higher, but still, those are the two strongest factors that we know that modulate that risk of MS. We also know that EBV laps B cells, and B cells play a critical role in MS, perhaps through that antigen presentation, amplification of inflammation. We know that if we knock down B cells, you have a robust clinical effect on inflammation in MS. So can we speculate that if we control and prevent, we were talking before with vaccination, could we cure MS? And I will pose that there. I don't have an answer for that. That's my hope. And those of you who know me, I'm not one to create false hopes. I'm really skeptical about things, but this is truly the first time that I'm putting the word curing in MS in one slide deck. So I hope you don't take that lightly. And with that, again, I want to thank the exhibitors and the sponsors, and perhaps pass this back to Kathy.
Excellent. Thank you so much, Dr. Miravalle, for your detailed explanation of the topic tonight. And huge thank you, Dr. Fling, for an excellent job on moderating. Of course, I would again like to recognize our sponsors, Biogen, EMD Serono, and Janssen Pharmaceuticals. Hope you all have a wonderful start to the week, and good evening. Thanks so much.